Hello everyone, welcome to my channel, and in today's video I'm going to discuss interpretation of arterial blood cases. This is a really important topic because whenever you are working in any acute medical setting, you are required to interpret ABG reports on an almost day-to-day basis, and sometimes it can be quite overwhelming when the patient is acutely deteriorating and you are having to look at a piece of paper with some numbers on it, and you need to come to the right conclusion of what acid or base abnormality this patient is having and what adjustment or what treatment you need to give to this patient. Okay, so for this purpose, I'm going to give you a systematic six-step approach to interpret any ABG report efficiently, and this will enable you to come to the right conclusions, and you will be able to make necessary adjustment to the patient treatment accordingly. Okay, so first of all, let's take a look at some normal values and this chemical reaction here. Okay, so this chemical reaction goes on in your body to maintain the pH in this normal range, which is between 7.35 to 7.45. Okay, and pH is basically the concentration of hydrogen ion in your blood. Okay, so basically this whole process is happening to maintain a normal concentration of these hydrogen ion in your blood. All right, so let's start at this end. So here you can see that carbon dioxide is combining with water to produce carbonic acid. So where does carbon dioxide comes from in our blood? Carbon dioxide is basically the end product of metabolism, and it is produced by every single cell in our body. When the cell is utilizing glucose to produce ATP, it gives carbon dioxide as the end product of that metabolism. And then carbon dioxide quickly combine with water to produce carbonic acid, and then this carbonic acid is then transported to the lungs, and in the lungs the carbon dioxide is exhaled. Okay, so carbon dioxide is produced by every cell in your body, but it is excreted by the lungs. So whenever you are having problem with CO2 concentration, that is, your CO2 concentration is more, it means that the problem is respiratory. Now, at this end of the reaction, a hydrogen ion is combining with a bicarbonate ion to produce carbonic acid. So where does the hydrogen ion comes from? The hydrogen ion, it can come from ingestion. So you can ingest the hydrogen ion by ingesting more acidic or acid-like substances, and it can be produced in your body under certain circumstances, like during diabetic ketoacidosis, when a lot of ketones are producing, and in stages where lactic acidosis is happening. So hydrogen ion can either be ingested or it can be produced inside your body. Okay, the bicarbonate ion is produced mainly by the kidney. So kidneys are the only organ that can manipulate this bicarbonate ion, and the kidneys produce the bicarbonate ion, basically buffer the effect of the hydrogen ions, okay, to basically maintain a relatively normal concentration of hydrogen ion. So whenever you are having problem with this bicarbonate ion, the problem is said to be metabolic, because kidneys are basically responsible for producing this bicarbonate ion. I hope this much is clear, because this is the absolute basic of arterial blood gas interpretation. Okay, let's discuss some of the normal values. So first of all, pH in the arterial blood is between 7.35 to 7.45. Anything less than 7.35 is said to be acidosis. Anything more than 7.45 is said to be alkalosis. Okay. Then we have partial pressure of carbon dioxide. Okay. So the normal partial pressure of carbon dioxide is between 4.7 to 6 kilopascals, or 35 to 45 millimeter of mercury. Different units are used in different countries, so feel free to memorize whatever units are used in your country. Okay, so either 35 to 45 millimeter of mercury or 4.7 to 6 kilopascal. You need to memorize that. Unfortunately, there is no other way around it. The partial pressure of oxygen is usually, in an average healthy person, it's around 11 kilopascal. Okay, I'm going to discuss this in detail in the next few minutes, which will help you to kind of remember this value. Okay, So bicarbonate ion, it's usually between 22 to 26 millimoles per liter. Okay. So between 22 26 is the bicarbonate ion concentration in the blood. Then basics is also between +2 to -2. Okay. So these five things, uh, you are going to have these five values on your ABG reports. Okay. The ABG machine sometime also sometimes the ABG machines are also able to calculate some other things like the hemoglobin concentration, electrolyte levels like potassium, sodium, chloride, etc. Okay. So these five things, these are the basic, and some ECG machine, there is some ABG machine, sorry, they can also give you hemoglobin levels and electrolyte levels. Okay. Okay. So let's discuss partial pressure of oxygen. Okay. So as we all know, in our normal inspired air, the concentration of oxygen is around, sorry, the concentration of oxygen is around 21% in our normal inspired air. And as we all know that the atmospheric pressure is 100 kilopascal, so it means that the partial pressure of oxygen is 21 kilopascal. Okay, because atmospheric pressure is 100 kilopascal, and out of that 21% is oxygen, so oxygen is exerting 21 kilopascal pressure. Okay, then when we inspire this air, inside our respiratory tract, there is addition of water and CO2 to this, inspired air. So by the time it reaches the alveoli, the concentration of oxygen drops to 13 kilopascal. Okay, because now the inspired air contain more water and carbon dioxide, which are added to it from our respiratory system. So in alveoli, the partial pressure of oxygen drops to 13 kilopascal. Okay. Then from the alveoli, this oxygen has to diffuse into the blood, and then the partial pressure of oxygen further drops during this diffusion. Okay, so in blood, the partial pressure of oxygen is always less than the alveoli. Okay, how much less? This difference will depend upon the presence or absence of any respiratory disease, the thickness of the respiratory membrane. Okay, but in a normal healthy person with no respiratory illness, the partial pressure of oxygen is 11 kilopascal in the blood. Okay, so 11 kilopascal. So it's only 10 kilopascal less than the inspired oxygen. Okay. So as a rule of thumb, the partial pressure of oxygen in the blood should be 10 less than the inspired oxygen partial pressure. Okay. So as we all know that when we go up, so on increasing altitude, the partial pressure of oxygen drops. Okay. So, or if someone is having oxygen through the face mask, then they are on high percentage of oxygen. So almost always as a rule of thumb, the partial pressure of oxygen in the blood should be 10 less than the inspired partial pressure of oxygen. So for example, if a patient is inspiring 80% of oxygen, if you are giving oxygen to the patient through a face mask and he's on 80% oxygen, and his ABG report shows that his partial pressure of oxygen is 11 kilopascal, then this is not normal. Okay, because this person is not inspiring 21% oxygen. He is inspiring 80% of oxygen. Okay, so his partial pressure should be 10 less than the 80%. It should be 70. It should be 70 kilopascal, not 11 kilopascal. Okay, so this is not, although it's like the normal average, the partial pressure of oxygen in the blood is like a normal average person, but this is not normal. It means that there is impaired oxygenation going on. Okay, there's some problem with his lungs. So this is not normal when a person is on any higher concentration of oxygen. Okay. Now, what are the six steps of ABG interpretation? So first of all, when you are looking at an ABG report, the first question that you need to ask yourself is, how is the patient? Okay. What is the clinical situation of the patient? What is going on with this patient clinically? What symptom is he experiencing? Okay. The next step that you need to, the next question that you need to ask yourself is the patient hypoxemic? Okay. Once you have established this, then you need to look at the pH. What is the pH? Then you need to look at the partial pressure of carbon dioxide. Then you need to look at bicarbonate and base excess level. And at the end, the last step is to ask yourself that are there any other important values to consider? For example, blood glucose level, um, electrolyte levels, blood urea nitrogen, hemoglobin level, etc., etc. Okay, so now we are going to discuss a few examples to kind of give you an idea how to interpret the report and how to apply these 6 steps. Okay, so first of all, let's take a look at this scenario. So our first scenario is a 25-year-old patient has been brought to the emergency room following a head injury due to a fall from a height and she seems to be deteriorating. You perform a rapid ABCD assessment. Okay, so whenever you receive a patient in emergency, any acutely deteriorating patient, you are going to perform ABCD assessment. Okay, what is the ABCD assessment? I will discuss in detail now. So first of all, you will check the airway. Okay, is the airway clear? So yes, the airway is clear. She's tolerating oropharyngeal airway and she's on 90% oxygen. So probably the ambulance crew has passed an oropharyngeal airway and started her on 90% oxygen. Breathing. So respiratory rate is 8 per minute. So you can see that the respiratory rate is low because for a normal adult person, respiratory rate between 15 to 20 is normal. So this is a low respiratory rate. Okay. So respiratory rate is 8 per minute. Oxygen saturation on pulse oximetry is 90%. Percussion note, it's resonant throughout. On auscultation, there is equal but reduced air entry in both lungs. Okay. Circulation. So in circulation, you check blood pressure, pulse, and capillary refill time. So blood pressure here is 160 by 100. So the blood pressure is quite high. Pulse is 60 per minute. Pulse is normal, almost normal, because the normal pulse rate is between 60 to 100. Okay. Disability. So in disability, you need to check pupillary light reaction, you need to check GCS level, and you need to check blood glucose level. But here we are only given GCS, and GCS is 9, which is low because normal GCS level is 15. On exposure, you find an abrasion on the left forearm. So basically, what's happening here is you have got a 25-year-old patient who was brought to the emergency department after fall from a height. Okay, and she has low GCS at the moment. She's unconscious because she's tolerating oropharyngeal airway. She has been started on 90% oxygen. Her respiratory rate is low. Oxygen saturation is low because normally oxygen saturation is about 95%. On examination of respiratory system, percussion note resonant throughout, which is normal. But you can, on auscultation, you find out that there is equal but reduced air entry in both lungs. Um, Circulatory system examination of circulatory system shows that her blood pressure is elevated, pulse is normal, GCS level is low, and there is abrasion on the left forearm. You decide to take an ABG sample and you have the report. So pH is 7.26. Okay, PaCO2 is 8.5 kilopascal. PaO2 is 18 kilopascal. Bicarbonate ion is 24, and base excess is minus 2.3. Okay, so let's apply our 6-step approach. The first question that you need to ask yourself is how is the patient? So you just perform an ABCD assessment and you know the clinical situation of the patient. The next question that we need to ask ourselves is the patient hypoxemic? Okay, because hypoxemia kills. All right, so the first question is how is the patient clinically, and the next step is directly about hypoxemia. Okay, so here her partial pressure of oxygen is 18 kilopascal. And if you remember, the normal partial pressure of oxygen in a normal average person is 11 kilopascal. So is this patient hypoxemic? No, because her partial pressure of oxygen is above normal. But this person was on 90% oxygen. Do you remember? This person was on 90% oxygen. So you would not expect her partial pressure to be 18 kilopascal. you will expect a higher partial pressure of oxygen. So it means that there is some impaired oxygenation going on. Something is wrong with her respiratory system. Okay. But she's not hypoxemic. Her partial pressure of oxygen in her blood is normal because you started her on supplemental oxygen. Okay. The next step that we ask ourselves is how about the pH? Okay. So the patient is acidemic because the normal pH is between 7.35 to 7.45. And if this is less than 7.35, so the patient is um, acidemic. Okay. Okay. So this was your third question, right? No, basically, yeah, this was your third question. So the fourth question is, um, what's PSU2 doing? Okay. So what's the PSU2 here? It's 8.5 kilopascal. 8.5 kilopascal. And if you remember, the normal partial pressure of carbon dioxide was between 4.7 to 6 kilopascal. So this is clearly elevated. Okay. So PSU2 is elevated. So now you know that the patient has acidosis and the patient's PaCO2 is elevated. So probably respiratory acidosis, right? Okay, now the next step is to check bicarb and base excess. Okay, so what's bicarb doing? Bicarb is 24. So the normal level of bicarb is between 22 to 26 millimole. So it's in the normal range. What's base excess? Base excess is normally between -2 to +2, and it's slightly less than -2.3, so it's slightly less. Okay. So we have gone through our sixth question. How is the patient? Is the patient hypoxemic? No, but there is impaired oxygenation going on. How about the pH? There is acidosis. How about PSU2? It's elevated. So, what's the conclusion? Respiratory acidosis. What's bicarbonate level? Bicarbonate is normal. What's base excess? It's just below normal. So, we don't have, there is no significant abnormality with bicarbonate or base excess. Okay. Are there other important values to consider? Yes, this patient has been brought with low GCS and you need to check blood glucose because this patient sustained an injury. She fell from a height. She probably sustained a head injury, and hypoglycemia can make brain injury worse. Okay, so you need to rule out any hypoglycemia. So, in conclusion, she has respiratory acidosis with impaired oxygenation. Okay. So the treatment will include improving her oxygenation, so probably passing a more definitive airway, okay, and assisted ventilation because her respiratory rate is quite low, it's 8. So we are going to intubate and ventilate the patient. So we will give assisted ventilation. It may be 15 breaths per minute, and it will help her to rapidly exhale that carbon dioxide and will return her pH to normal. Okay. So I hope this scenario was clear. Let's take a look at another scenario. So you have a 63-year-old patient. 63-year-old patient is brought to the emergency room following an out of hospital cardiac arrest. Okay, so a 63-year-old patient, um, he arrested in the community. There was a cardiac arrest, and then he's been brought to the ER. When the ambulance crew arrived, he was in ventricular fibrillation and got spontaneous return of circulation after the second shock. Okay, he has been intubated and is on 50% oxygen. Systolic blood pressure is 130, and ECG is showing sinus tachycardia. Okay, so what actually happened here is a 63-year-old patient has had a cardiac arrest at his home, and then an ambulance was called. When the ambulance arrived, the patient was in ventricular fibrillation, and they started a CPR. And there was a spontaneous return of circulation after the second shock because ventricular fibrillation is a shockable rhythm. So the ambulance crew must have shocked him. Um, After the spontaneous return of circulation, he was intubated and he's on 50% oxygen at the moment. His systolic blood pressure is 130 and ECG is showing sinus tachycardia. Okay. The ambulance crew has also taken an ABG sample and you have the ABG report. Okay. All right. So we are going to interpret this ABG report using our 6-step approach. How is the patient? So you already know You've been told the details here. Is the patient hypoxemic? Okay, 7.5 kilopascal. Is this hypoxemia? Yes, because the normal partial pressure of oxygen is 11 kilopascal, and this is less than 11 kilopascal. So yes, the patient is hypoxemic. Okay. What is the pH doing? The pH is 7.1. So there is acidosis. What is PaCO2 doing? The PaCO2 is 7.6 kilopascal. Okay, and the normal PaCO2 is 4.7 to 6 kilopascal. So this is more than 6 kilopascal. So yes, PaCO2 is elevated. Okay. What is base X's and bicarbonate doing? Okay. So bicarb is 16 millimole per liter. Is it normal? No, because normal bicarb level is 22-26 millimole per liter. So this is less than 22. So the bicarbonate level is low. What is the base X doing? Base X is minus 10. Okay. Normally it's between -2 to +2. So minus 10. So yes, the base X is really, really low. So in conclusion, the patient has hypoxemia. The patient has acidosis. Is it respiratory acidosis? Because PaCO2 is elevated. Is it metabolic acidosis? Because bicarbonate is low. So it's probably both. Okay, it's a mixed respiratory and metabolic acidosis. Okay, so let's take a look at the slides. How is the patient? How is the patient doing? You have been provided details. Is the patient hypoxemic? Yes, the patient is hypoxemic because partial pressure of oxygen is less than 10 kilopascal. Also, he's not breathing on 21% oxygen, remember? He's not breathing on normal air. He's breathing on 50% oxygen. So you would expect partial pressure of oxygen to be around 40 kilopascal. Okay, 10 less than the inspired air, 40 kilopascal. But you have 8 kilopascal. So it means that there is severely impaired oxygenation going on. What is the pH? There is acidosis. What is PaCO2? Elevated, consistent with respiratory acidosis. What is bicarbonate and base X's? Bicarbonate is low, base X's is low. This is consistent with metabolic acidosis. Okay. So, other important values to consider will be electrolyte and glucose. Okay. So basically, what happens during a cardiac arrest is there is anaerobic metabolism going on in the body. Okay. So during anaerobic metabolism, lactic acid is produced. Okay, and there is acidosis in the body. And the bicarbonate is used to buffer the effect of those acids. All right. So the bicarbonate level falls. And this gives a picture of metabolic acidosis. But during a cardiac arrest, the patient is not breathing either. So the patient is not able to exhale carbon dioxide. So the carbon dioxide level rises and it gives a picture of respiratory acidosis. So a mixed metabolic and respiratory acidosis goes on. Okay. So in conclusion, this is a typical ABG after prolonged cardiac arrest. There is mixed metabolic and respiratory acidosis, but the predominant component is metabolic with significant impairment of oxygenation. Why do we say that the predominant component is metabolic? Because the bicarbonate level is really low. It's 16, and the base X is -10. It's significantly low. And also during a prolonged cardiac arrest, there is significant anaerobic metabolism and large amount of lactic acid is produced. And then the bicarbonate ion is used to buffer the effect of that lactic acid. Okay. There is also significant impairment of oxygenation in this patient. So what we are going to do based on our conclusion, we are going to increase the minute ventilation for this patient. So we are going to increase his, because he's being ventilated, so we are going to increase his respiratory rate, and this will help him to quickly exhale the carbon dioxide. And quickly exhale the carbon dioxide. We are also going to increase his level of inspired oxygen. Okay, so he's 50%. We'll probably start him on 90 to 100% oxygen, and this will increase his partial pressure of oxygen in the blood, and there will be no more hypoxemia. We will also increase his minute ventilation. So probably to 10 to 15 breaths per minute, and this will help him to quickly exhale the accumulated CO2. So these measure will help him to, quickly compensate his pH. Okay, let's take a look at the third example. So what's going on here? A 69-year-old patient was admitted with infective exacerbation of severe COPD. Okay, so this is a patient who has diagnosed COPD and he has been admitted with infective exacerbation. He seems to have had a respiratory arrest. Okay, so during admission, he was found to have a respiratory arrest. The nurses found him unresponsive and not breathing, but they could feel a pulse. Okay, so it's not a cardiorespiratory arrest because there is still a pulse, but he's not breathing and he is unresponsive. An oropharyngeal airway was passed, and they were bagging him with 100% oxygen. Okay, so bag mask ventilation is going on. The monitor shows that he is a bit bradycardic, and the partial pressure of oxygen is 98% on pulse oximetry. Oxygen saturation is 98% on pulse oximetry. So you have a 69-year-old patient, diagnosed case of severe COPD, presented with infective exacerbation. He was found to have a respiratory arrest, which means that he was not breathing and he was unconscious, but there was a pulse. Okay, so it was not a cardiorespiratory arrest, it was only a respiratory arrest. The nurses have secured his airway by passing an oropharyngeal airway, and they were bagging him with bag mask ventilation with 100% oxygen. Monitor was attached, and it shows that the heart rate is a bit low and partial pressure of oxygen saturation on pulse oximetry is 98%. Okay, so you have you have taken an ABG sample and requested an ABG report. The ABG report come back and let's interpret it using our 6-step approach. So, sorry. Okay, so first of all, the first question is how is the patient? So you know about the patient clinical background. Um, is the patient hypoxemic? What is the partial pressure of oxygen? 19.5 kilopascal. It's more than 11 kilopascal. So no, the patient is not hypoxemic. But if the patient is, they are ventilating the patient with 100% oxygen. This is not the partial pressure of oxygen you would expect in a normal person who has been breathing 100% oxygen. So it means that impaired oxygenation is going on, probably because of his severe COPD. Okay, the next step is to look at the pH. What is the pH? 7.26. It's less than 7.35, so it is acidosis. Okay, let's take a look at PaCO2. PaCO2 is 14 kilopascal elevated. Okay, so it seems like respiratory acidosis because PaCO2 is quite high. It's much higher than 6 kilopascal, which is the normal upper limit. So yeah, respiratory acidosis. What's bicarb and base X is doing? So bicarbonate level is 36 millimole per liter. Okay, and base X is 12 millimole per liter. Both are elevated. Okay, so this is basically giving a picture of metabolic alkalosis, basically metabolic compensation of his respiratory acidosis. Okay, other important values to consider will be his electrolyte levels, his glucose levels, and his renal function. Okay, how is the patient? You have the patient clinical background. The patient is not hypoxemic because 19.5 kilopascal of partial pressure of oxygen, but there is impaired oxygenation going on. pH shows acidosis. PaCO2 is very high. Okay, so this is due to basically the prolonged period of apnea. He was not breathing for some time, and there is an underlying COPD. So he has been retaining carbon dioxide chronically because of his COPD, and on the top of that, there was a brief period of apnea because he went into respiratory arrest and was not breathing until the nurse found him and they started him on assisted ventilation. Okay, so there is very high level of carbon dioxide in the blood. So this is respiratory acidosis. Okay, regarding bicarb level, quite elevated. So this is a compensatory mechanism for his long-standing COPD. So Prior to his respiratory arrest, this compensation would have resulted in his pH being normal despite an increased PaCO2. So basically, this patient is a COPD patient. So he has been retaining carbon dioxide for quite some time now. Okay. So, as a result of his chronic respiratory acidosis, the body has compensated. The kidneys are producing much more bicarbonate level in an attempt to kind of buffer the effect of carbon elevated level of carbon dioxide. Okay, so normally before his respiratory arrest, this increase in bicarbonate ion was able to maintain his pH in a relatively normal level. But now on the top of chronic retention of carbon dioxide, there was a respiratory arrest as well. The patient was not breathing for a few minutes, okay, which has resulted in even more carbon dioxide retention in the blood. So the compensation has failed now because kidneys cannot produce bicarb that quickly. Okay, kidneys are relatively slow to make bicarb. Okay, so now the compensatory mechanism has failed. This level of bicarb is not able to, compensate the effect of this additional level of CO2 in the blood. So that's why you are seeing a drop in the pH. All right. Other values to consider will be, as usual, hemoglobin level, glucose level, and urea electrolyte. However, in this patient, you will be expecting an elevated level of hemoglobin because he is a COPD patient. Okay. So, in summary, what's going on here? There is an acute respiratory acidosis on the background of chronic compensated respiratory acidosis. Okay, so this is basically an acute on chronic picture. So basically, there was a respiratory acidosis going on because this patient was retaining carbon dioxide because of his um, lung disease, which is COPD. He was not able to exhale CO2 normally. So he was retaining it, and the kidneys were producing bicarbonate ions, much more amount of bicarbonate to kind of compensate the effect of that elevated CO2. And this was giving a normal pH. So there was a compensated respiratory acidosis. But now there is acute respiratory arrest, which has aided much more amount of CO2 on the top of chronic retention, and this has failed the compensatory mechanism, and now he is acidotic. What we are going to do for this patient? We are going to intubate this patient and ventilate. Either we are going to do non-invasive ventilation or we are going to intubate and ventilate. We are going to um, increase his minute ventilation. So he will be able to exhale more and more CO2, and this will probably help him to, bring his pH level back to his normal. Okay. So we have discussed three different clinical situations. The only other clinically important situation that I can think of is an ABG picture in a patient with diabetic ketoacidosis. So this video has been going on for quite some time. So I will discuss the ABG picture in a DK patient in the next video soon. I hope this was helpful, and I will see you soon with the next video.